Hello, 5 Minute Physio. So you just have to request to be live and then we will go live. Here we go. So that should be starting now. There we go. Hello.
Right.
How's it going?
Good. How are you?
Oh, not too bad. Just busy running around all day pretty much. So
That's better than sitting at home, though. That's for
I
sure.
think so. How's your day? How's Calgary?
Calgary's sunny today,
Yeah,
which is nice because
that's good.
it's been kind of cold the last couple days. So hopefully get outside for a bit. I feel like I'm going to get really excited and start talking like this, so you'll just have to tell me.
No, that's perfect. Excitement's good. This is good. I'm glad
Get
to
really
do this.
fired up about knees, that's for sure.
I like it quite a bit. I've seen quite a few ACLs, but I wish I could see more.
Oh, I know. I
The
could.
follow-up's hard sometimes, but
Yeah, it's long. It's
yeah,
definitely long, and I think there's a value in it being long. But I mean, I think with our system, especially like patient dependent, a lot of people they want their 6 weeks of rehab and then they want to be done, which poses kind of a challenge in itself, right? They
yeah,
have an expectation, or they've been told like, yeah, it's 6 to 8 weeks and then you'll be back to normal, when that's quite unrealistic for a big surgery like that.
for sure. Yeah, I know at the previous place I used to work at, they had the AHS contract, like the ortho contract,
Mm-hmm.
and then they cut that. Like there's still some there, but there's not as much as it used to be. So then it got really hard to plan someone's rehab in 7 sessions versus like 15 or 16. Um,
Totally.
so yeah, I found that was difficult. I mean, everyone that I've treated did pretty well. Um,
Yeah.
and I know we'll get into it, but it's tricky sometimes to get positives on like pre-surgical. Sometimes it's like, oh, it's not, that can't be a grade 3, and then it's like, nope, it's a grade 3.
Yeah, that was one of the big things I wanted to talk about, was the testing and how like that turgor, that swelling in the knee,
Yeah,
because we aren't typically as physios, we're not typically on field or on ice.
yeah,
Really easy to miss those, but it's not necessarily like you're not missing it. It's just
no,
it's not there, right?
yeah,
And then 1 or 2 weeks later, as that swelling comes down, you're like, no end feel here.
yeah, that's true. Um, yeah, a few cases like it wasn't too difficult to figure out. Like I had one one athlete, and it was like maybe 5 or 6 weeks, and I'm like, this just isn't, it's not progressing well. I'm like, I think you need some more imaging. Like there's something, and it ended up being a rupture, and it was like a significant PCL issue too. But
Yeah,
I
it always
hate
kind of,
a lot of PCLs.
I find that, I don't know if you find this too, but I've had a few where, like they'll come in and I'm like, I'm like, okay, like pretty sure it's full ACL here, but like, let's get your imaging. And then their pain is pretty good. Like they're pretty functional.
Yeah,
And then it comes back and their MRI is like a mess, like ACL, MCL, meniscus. And then you have those other ones where you're like, yeah, like the end feels there, but like you are just like
yeah,
so debilitated, and like you're just like not fitting this picture, and then the MRI comes back like grade 1, 2, and you're like, okay.
yeah. So like, I didn't see that. Yeah, it's interesting when you get into like you in school, you look at the textbook stuff,
Yeah.
um, and it's all about the practical to like it just changes. Like the textbook's not wrong. It's just you can't possibly explain like these are all of the signs and symptoms of a grade 3, um, because you get that immediate swelling, which I guess we'll touch base. I guess I should introduce you now that lots of people are in,
Yeah, quite a
and
few.
then you kind of just talk about like education, like a brief thing on education, like where you're working and what kind of stuff you like doing. So this is Michaela. She's part of 5 Minute Physio, which is a sweet thing that I love following and envious of them. Hopefully I could be like 5 Minute Physio with 3 of us at one point, but that's okay.
Yeah.
So she's a physiotherapist in Calgary, and I'm super excited to have her. Her colleague Laura was on last week, and yeah, so like I'm really happy. I thank you so much for attending, and I'll let you take it away and talk about you.
Okay. Yeah, you pretty much said it all. So I work in Calgary at a LifeMark, in the Northeast here. I graduated with Laura in December 2018, I guess it would have been, I think. Um, And then she worked in Edmonton, I worked in Calgary, but we've been steady pals ever since. And then when this kind of COVID thing took over, we were chatting on FaceTime, and I kind of had this idea that I wanted to start a physio Instagram, but I didn't really want it to be just me, and I didn't really want it to just be there's like, it's them saturated on Instagram with a bunch of really great physio content. So I wanted to really try and make it like patient friendly so that people could do them, especially because I have a lot of friends and family that ask me like, oh, send me some exercises. So it was kind of just an easier way to bring kind of 5 minutes of exercise. And then, yeah, I've been working with the Banff Sports Medicine team. So LifeMark has partnered with them and does all their post-operative testing. So we do that once a week on Wednesdays, what we used to. Hopefully get back to it soon. But we basically run through post-op testing for ACLs and MPFL injuries 6 months and 1 year after their surgery date. So we work with 4 surgeons, Dr. Hurd, Heemstra, Kopka, and Dr. Bushko. Really wonderful surgeons, and like certainly very helpful to kind of have that face-to-face time, especially on slower days in the clinic where we can ask questions. So a lot of the information that I've had and like the knowledge that I've gained over the last couple months is like strictly thanks to them and the other physios that are on board, which has been definitely really helpful. I feel like if I had that experience for every body part, I'd be a way better physio, but one at a time. Yeah.
That's awesome. That's a very unique like opportunity too. I know we chatted about it last week. Actually, the weeks are like blending in together. I don't know what day is what anymore. But
I thought today was Saturday, so.
I know I'm at work and I'm dressed accordingly, so that's good enough.
Yeah.
So yeah, like I know we talked about it, and that's really like same with you. Like that's why you and Laura are so unique, because you have like pretty unique work experience that I know a lot of people don't necessarily get. So
yeah, I think it's really important to like put yourself out there, especially being like younger in the field too. I think it's pretty easy to just kind of go about your caseload, and I think if you could put yourself out there and collaborate with people, like meeting you through this platform and things like that, I think it's super valuable.
Yeah, it's cool. Like I like it because, like you just mentioned, like you meet more people and a lot more professional relationships get made, and you know, a third person can be added to the 5-minute physio crew. Just saying.
We'll send you a contract.
Oh, a contract. I thought there was going to be an interview or like some sort of like screening process.
Basically, you just have to put up with me telling you the lighting's bad in your video, and then you're fine.
This place has adjustable lighting. I can turn it down. I can dim it.
Laura gets a little bit of crap for her lighting sometimes because the green carpet really shines through sometimes, and I can't tame it.
I'll get the green carpet installed.
Okay.
It's coming. It's easy to find with some of the older homes in Edmonton.
Oh, for sure.
I'm just going to line this up to the computer here. And that's the hydroculator, or that's the heat pack covers in the back. So there we go. I have it
here on my computer too, so I can kind of follow along and point out too.
So this is a presentation about post-operative ACL rehab. Michaela's going to do most of it because she's the specialist, and I'm just going to eat my lunch. Just kidding. No, I don't have my lunch right now. But yeah, so I added, like I said, I added a couple slides in it just to kind of talk about some prehab. I know this is most post rehab, but we'll talk about a few things, and I will be your vessel. So you tell me when to switch slides and stuff.
All right.
Yeah.
Let's go. So first slide here, just kind of a review. I know from what Sunny's told me that we kind of have physios and patients kind of on the live. So your ACL is one of 4 really important ligaments in your knee, seen right there. Okay. And I always kind of explain it to patients. It's if you're holding a pencil in your right hand, that's basically how it travels. I think that's the easiest way to remember it versus like trying to understand exactly where it articulates and things like that. But its big job is basically to stabilize the knee and prevent your tibia, so the lower leg bone, to go forward. So your anterior translation of that. So that's the big role of it there. We go to the next, this picture here, and we see how it kind of is related to your MCL and your medial meniscus. So I don't know if this is called this anymore. I looked this up, and apparently they've stopped calling it this. But it's called the unhappy triad.
Oh, yeah.
Yeah, it kind of interesting. I don't know if that's real, but according to Google, we don't call it that anymore.
Yeah.
Thing.
I used to call it the terrible triad.
Or terrible triad or
Yeah.
unhappy triad, but apparently they're saying that this isn't correlated anymore, but I don't know. I've seen a lot of these. So
well then, I have too.
yeah, we're going to call it the terrible triad or unhappy triad. So just remembering how those three structures are related and making sure that you're testing that accordingly. And then also here I put in just kind of a picture of a medial meniscus root tear. So you'll see at the top, kind of to the right there, that's actually the back of the knee. So that's the posterior aspect, and that's where the root is. So the meniscal root is actually one of the key attachments of that meniscus to the tibial plateau. So that's something I actually didn't really know a ton about until I started working with the surgeons and how that meniscal repair in general. Sorry, I'm just reading this thing. Oh, a patient here has got their thing postponed. Okay.
Yeah.
Yeah, this is probably going to be cool for you.
This is
sorry,
going to be special for you.
I'm like a squirrel person. I get very distracted. But anyways, so the meniscal repair meniscal repairs are specifically the root repairs, and how are rehabs different based on that. So if you go to the next slide, we'll maybe touch base with that, and then I'll kind of do what I've learned with working with meniscal repairs. This next slide here is a really great read, especially for physios. Just a clinical commentary on meniscal root repairs. If that's not something you're familiar with, or maybe you've seen it on a referral from a surgeon and you're like, I don't know what this is, and you've done a little bit of research, this is one of the best kind of clinical commentaries I've read anyways. And it's just looking at why they have poor healing. So I kind of highlighted it here in that second highlighted blurb. So what they do, they're one of those anchors to the tibial plateau, like I said. And then this article also talks about the hoop stress. So that's basically like your weight bearing. So as you stand, that's when that root is being kind of stressed or used in that setting. And so with root repairs, those are ones that, especially working with the BAM Sports Med group, we really baby. So maybe those aren't the people that at 3 months post-operative, you are aggressively starting that plyometrics or that jumping. You're really taking things slow. And one of the big reasons behind that is that there's actually no way for them to know how that meniscus is healing, right? So we can't necessarily do a stress or scour test and get super accurate findings compared to like doing a Lockman's, where we can see that laxity kind of later on in rehab, especially as that swelling comes down. But for meniscus repair healing, they're basically looking at kind of the pain and swelling response, which obviously has a bunch of other factors involved with it too. So anytime there's a meniscus repair or specifically a root repair, it's really decelerating, so slowing down your rehab quite a bit.
Mm-hmm. Next slide, I assume.
Yeah, well,
no?
There's one more thing there. I just want to see if you had anything to add to that.
No.
No. Okay. And then, so the biggest thing from this study, which I put on here, because I find that sometimes we get really nice referrals from surgeons that dictate non-weight bearing expectations, things like that, no hamstring contractions. But this clinical commentary actually has a really nice, like, phase by phase for root repair. So they've taken a bunch of randomized control trials and put them together and made kind of a nice summary of it. So the biggest things here are the non-weight bearing. Like I said, that axial load is what stresses that root repair. So that's why we have a weight bearing restriction for 6 weeks. And then also that flexion restriction. So similar in any meniscus repair, we typically aren't forcing flexion for the first 3 months or 12 weeks. And then another thing for the root repairs is the hamstring contraction. So like no isolated hamstring activation in that first 6 weeks, just because of that attachment of the hamstrings to that posterior aspect of the meniscus. So something interesting, if physios that are watching maybe haven't heard of a root repair or haven't treated one or haven't worked with one, just to remember that it's not you, it's not the patient. They are a little bit slower to rehab, just like meniscus repairs in general, different than how a meniscectomy would be. So if they just scrape out the meniscus. So being able to preface somebody's rehab and just helping them understand, like, oh, why is patient B doing all this stuff and already there? but when the surgeries are actually quite different. My mom gave us a thumbs up, so that's
Oh,
good.
nice.
I'm doing a good job.
Hello, Mom.
Thanks, Mom. Okay. We'll move on to the next slide here and just touch on the different ACL grafts. This was one of the biggest questions I asked the surgeons when I started working with them. We hear about the patellar tendon grafts and then the hamstring graft. I was really curious which hamstring they took it from. So it's typically semitendinosus, but they can use gracilis as well. So they either do like a 2-strand or a 4-strand approach. Again, I'm not a orthopedic surgeon. This is like my very dumbed down knowledge of it. But really interesting when you think about kind of where that secondary injury is or where they're taking that from. I think it's important to remind ourselves that. So if we look kind of gracilis is obviously one of the long adductors, and then semitendinosus is one of the hamstring muscles, more on the medial aspect of the hamstring. So just important to remember that that's what they're taking it from. I found that was really valuable for me to know, kind of wrapping my head around like where they were taking it from, what anatomy was exactly involved. And then remembering on the next slide that 2 of those muscles, so gracilis and semitendinosus, are involved in our pes anserine attachment. So pretty common. I don't know if any of you've experienced this too, but a lot of kind of persisting pain, or especially on that medial side of the tibia or the lower leg. And remembering there is a bursa there. So kind of just trying to wrap around how the surgical approach or like the surgical surgery itself will affect that, right? So which part of your rehab are you able to change, and then other parts that just might need a little bit of time, or the scar tissue might need to let settle down a little bit.
Yeah, I've noticed those things with the pes anserine and the goose's foot.
Mm-hmm.
Yeah, so I've noticed that linger around too quite a bit. So yeah.
And then the other thing I should mention with the grafts, the next slide is a study about which graft is better, because that's obviously a huge question we get from patients. Oh, well, which graft should I get? Or they want to do this graft. And I've heard this from my friend, things like that. But one important thing for physios is to really look at the incisions. So the incisions tell you a ton about what surgery they had. So in a minute, we'll talk about the LET techniques on the outside, but remembering that those hamstring grafts, even if the patient can't tell you what they have, you know that hamstring graft is going to be on the lower leg. It's kind of on an angle. It's longer or shorter depending on whether they've had a cadaver or they're using their own hamstring. And that's just based on the age of the patient typically. And then also, I guess I've heard that it's based on kind of what they have in the cadaver lab too, right? So if ideally the patient would get a cadaver, but there's none there, or it fails or something like that, I've heard that it's kind of switched last minute as well. But then also just, yeah, like I was saying, look at the incisions, because I'll actually tell you a lot of information, because I've certainly had patients come in that can't tell me what they've had done, if they've had any other work done to the knee previously or anything like that. So I think taking time to really do that observation point or process of your assessment is so valuable post-operatively.
Yeah.
And then, so I put in one study here about a meta-analysis of which graft is better. Fairly inconclusive. My understanding from what I've heard from the surgeons is it used to be a lot of patellar tendon grafts. I'm sure you remember that, Sunny, and then it kind of shifted to hamstring, and now it's kind of shifting almost back a little bit. And then when I've asked almost all the surgeons kind of what they do most, and just what I've seen, certainly a lot of surgeon preference, and then also dictated by what the patient wants to do. So if somebody has a kneeling sport or a kneeling job, obviously the patellar tendon graft is probably not the best option for them, just because kneeling is a little bit challenging following that. But definitely really inconclusive evidence around which graft is better from a function and pain kind of standpoint. Do you have any experience? Do you have one that you find rehab's a little bit better?
I always find the hamstring ones were a little bit better than patellar, for instance.
Mm-hmm.
And I know some cases there was the cadaver ligaments that were used as well. And I find the patellar ones, nothing crazy significant, but I always found the hamstring ones were a lot faster to get back to activity.
Yeah, I think it also is kind of, I mean, it's really hard to say A is better than B when like your patient population is so different for like cadaver versus their own, and then also patellar versus hamstring. So I think if you took like a bunch of clones that all did the same sport and stuff, it'd be interesting to compare them that way. But you think about the people that maybe have like more kneeling occupations or kneeling sports. Like I'm thinking like even more like rugby or something like that, like
Yeah.
them versus like a badminton or like a soccer player, it's so different, right? The degree of contact and things like that is fairly different. So I think it's hard to say. It's like that's why the studies are so inconclusive, in my opinion, is that not only are the grafts so different, but also the patient population tends to be so different. So how are they really controlling for the two different subgroups, right?
Yeah, for sure. It's tricky.
Super tricky. Next slide, please. And then this is kind of the last really wordy bit of research, but this is just a 2020 study. So this is pretty new, pretty relevant here. So this is what I was talking about with the LET. So it's a ladder extraarticular tenodesis. So what they're studying is that basically, this is again a super dumbed down version of what actually happens, but they're taking a portion of the lateral musculature and the IT band, and they're reinforcing the ACL with that. So they're studying this in really high risk groups of graft failure. So this is a study that I believe Dr. Hurd kind of is spearheading, and he published this in, like I said, January 2020, and then finding that it's kind of small here, but no changes in kind of patient reported outcomes that were significant, but there was a significant reduction in the graft failure rate in these people. So definitely something new that they're newish that they're doing, and then super interesting to just kind of watch it. And then that's something, again, checking the incisions to see if your patient did get an LET, even if they're not aware of it. It'll be a big incision on the lateral side of the thigh. So something to look out for. Have you seen any of those, Sunny?
I haven't. No, when you sent me this, I was pretty interested in it. So I haven't seen too many. Yeah, I definitely, I can see the benefit of it for sure.
Totally. It'll be interesting to see. I mean, I've assessed a couple like at the knee clinic. I think I've seen two, and like really no differences that I've noticed functionally for them. A little bit of tightness, obviously, through that lateral side of the knee was one of the like most common things that they told me, but I haven't seen too many. So it'll be interesting to see kind of how their post-operative protocol changes related to this, or if it does need to change or things like that. But definitely something interesting for all the physios that are watching. If you haven't heard of this, I think it's going to become more common as a surgical approach or a surgical technique to help, especially with those younger super bendy athletes that are getting ACLs done quite early in their lives.
And you got to keep me updated with that.
Yeah, I will for sure. Hopefully we're off of the clinic until September, I heard. So hopefully once we get back, then we'll be super busy.
I mean, you'll be flying between Vancouver and Edmonton anyway, so still, like,
yeah, I'm going to be super busy.
It's all good.
Okay, next slide here. Okay, so we'll kind of finish the slides here, but I just wanted to, in case you post this or people are curious, all the BAM Sports Medicine research is posted on their website. So especially in this time where maybe all the physios aren't necessarily working their full hours, or we're having to wait between patients and things like that, a really good option for reading some research that very high quality, very well done, very digestible. So that's kind of what I would recommend. And then we'll go maybe through the exercises through the protocol after, but that's the protocol that I used for all my ACLs, whether they were done by the BAM Sports Med team or referred from a different surgeon. I know it's evidence-based. I know they've done a ton of work and testing to bring an evidence-based option. So I'm pretty loyal to that one, but then definitely have some like tips and tricks for how to overcome some of the more common challenges that ACL rehab faces. So maybe we'll finish the slides and then I can get you to show some exercises if that's okay with you.
For sure. Good thing my legs are nice and sore today.
Okay, perfect.
I always say that and everything, but yeah. So everyone, if you do want the links for that, just let me know. or let either one of us know, and we can send it to you guys. So just send us a direct message. Yeah.
Totally. Okay. And then I thought this was interesting. So this is the testing that we do at the clinic at 6 months and a year. So we do the swipe test for swelling. So measuring kind of what swelling is still pocketing in that knee. Obviously measuring range of motion. We're measuring for a quads contraction. So good contraction comparable to the other side. Is it sustainable? Is it kind of flickering? That kind of thing. We do measure quad circumference, which is not something that I routinely measured in clinic before. But it is kind of a nice way, especially if people are wanting to kind of have some objective outcomes to measure with themselves over time. Obviously that strength, that hypertrophy of the muscle takes time, and it's not necessarily the perfect indicator of strength or function, but it's something to monitor and something that they can monitor on their own, which I think is really valuable. Sensation testing, so checking for any nerve damage, specifically down kind of in the lower leg there. We do see some kind of residual sensation deficits. Usually they improve or go away, but sometimes they don't. Not typically a big complaint of patients. And then we do our Lockman, pivot shift, and MCL stress testing with all patients. So the physio will do it, and then the surgeon comes in and does it as well, which is really helpful because you get a really good feel of what a positive is, especially if you do have somebody that is a grade 3, you're feeling like 30 or 35 knees, right? So you're feeling them back to back with that surgeon who's opened up that knee and can kind of tell you exactly what you're feeling. And then something I didn't know with the ligament stress testing is how that changes when there's meniscus involvement. So the way it was explained to me is that the more work they've had done to that meniscus, the more laxity that is expected, which is not something I knew. So when you're testing left to right, if you know this person has had a meniscectomy or has had a meniscus repair, you might get a little bit more of a play there than you'd expect following just a plain ACL injury. Does that make sense?
Yeah, that's pretty interesting. Yeah, that does definitely make sense.
Yeah, so I had no idea that, especially in that older population that might just get an ACL reconstruction as well as meniscectomy. So they're kind of scoping out the meniscus for them. A little bit of extra play is quite normal. So always comparing side to side, but also really just trying to assess that end feel, right? So making sure that you do feel, okay, am I just keeping going? Am I getting some of that hamstring now? Or is it a pretty firm end feel through there, right?
Yeah.
So I didn't know that. That was super interesting. And then from a functional testing perspective, balance is a huge thing that we measure. So we measure how long they can stand on a half Bosu ball on one leg. And then we measure that at 6 months and a year to see kind of how they've progressed. We look at double leg squat, single leg squat quality, single leg hop downs, which we'll go through about kind of how I start on with those plyometrics. And why they're so important. And then we do a bunch of plyometric testing, which again, you can demonstrate if you'd like afterwards. Yeah. But really nice to know what's, for me anyways, kind of starting to work with a lot more post-operative patients. It's really nice to know what's expected at 6 months, because I think that gets really hard to frame your rehab around like what are realistic goals, because obviously return to work are super important goals for patients, but maybe kind of toning it down and saying, okay, like I want you to be able to do 30 seconds of balance on this foam surface by the end of month 2 or something, right? Yeah. So you're giving them these objective goals that they can kind of work towards. And then I find that people are a lot more diligent with their rehab if you're giving them concrete numbers. So if you're working on a single hop, you're measuring it every time. So you're measuring, okay, you got 0.6 meters today. And it doesn't really, like, there's no evidence to say that 0.6 is better than 0.9, but you're giving them that feedback, right? So they're seeing how they're progressing, which I think is really important.
Yeah, for sure.
Okay. And then, yeah, kind of getting more into the post-operative concerns. So I'll just kind of shed light on some things that I've noticed a lot, remembering that their feelings of apprehension, a lot of the time, ACL injuries it's not just one injury and then you have a full ACL rupture. It's typically over time, like that repetitive stress. And then one is kind of the failure one. So a lot of them, and there's long wait time. So like our, I think Allie, yeah, she said goals would definitely be helpful post-rehab, but Ali was saying she's been waiting a while for her ACL surgery. It was pushed back because of COVID, but these patients are waiting from like 1 week to 8 months for that consult and then getting booked for surgery. So they're functioning on like a not optimal knee for a long time. So that apprehension with like bending or using the knee is really, really common. So how do we build that up? How do we build up that connection from the brain to the knee? And we can talk about some exercises that I've found really helpful for that, but that's definitely a huge concern that I have. And then obviously more with the hamstring grafts, that pain or stiffness through the hamstrings. So I always often remind patients that that is an injury. A lot of that stiffness that they find, I find is usually more strength related. So making sure that we are training them like Laura went through last week. And then the numbness into the knee or the lower leg, which I said usually gets better. Sometimes it doesn't, but not super functionally limiting for people. I don't see a ton of complaints about that. I think I've seen one person that was really unhappy with the numbness that was in his knee. So, and then, yeah, so the lack of knee flexion and weight bearing tasks. So that failure of them to like fully bend the knee symmetrically to the other side comes down to a lot of that apprehension. So they haven't been able to trust that quad for a really long time, trust that knee from giving way. So I'll talk about some ways that I kind of train that and work with people on that. And then knee swelling, it's healing. So the graft is healing for up to 2 years. That's what their kind of in vivo experiments have shown, that the graft is healing that entire time. So swelling, we know, is a healing response. So not something I tend to get people to worry about too much, but keeping them aware of it can also be a sign of like a lot of sudden swelling, can be a sign of that meniscus repair maybe not healing as well as we want it to. So maybe toning back rehab if you are getting a ton of swelling and pain response as well. Asymmetrical quad circumference. I don't know, Sunny, do you really emphasize this? I notice it and I get them aware of it, but I don't necessarily emphasize it a ton.
No, I don't. I just make sure people understand it, why it's happening, just to get them to do some more exercise and understand the seriousness of it. But I don't really measure directly.
Yeah, yeah. I'm the same. And I really do emphasize, I mean, especially for people that are really like, if they are that athlete that's like, my quad is so small, my quad is so small, I really try and emphasize the importance of single leg rehab, because you can do, I mean, I've had patients that I've watched them do squats and things like that, and all their weight's on their not affected leg. And I just try and really emphasize that like there's so much value in really like biasing your legs differently, because they are different right now and they need different strengthening, right?
Exactly.
And then, yeah, the laxity differences I talked about with that meniscus repair. So we got that. Okay, take it away. Do you want me to put the slides on me so you can put your face on and talk about
That's okay. People have seen my face more than enough. So building on that, atrophy, 3 exclamation points behind it, because people always talk about it. People always comment on it, and to a certain extent, it's gonna happen when you have one of these injuries. Like, you can't really prevent it because you are going to be reducing weight bearing. You're going to change the way you're using your leg. So the first point there, reduction of strength and power of quadricep, that happens with this injury. You have an altered neural functioning. So, and that precedes the atrophy, right? So you get injured, there's a reflex loop. You're not going to be putting weight on it. You're going to be, cautious of it to protect yourself. So that happens before the atrophy happens. Atrophy takes some time. It's from a failure of voluntary activation from the central nervous system to the quads. And this is to show that it's just more than the injury process. Like, you do have the whole body involved, so the central nervous system as well. It's bilateral, meaning both sides. So they've seen decreases in muscle bulk activation on both sides. So just like how you mentioned earlier, it's the different leg, or each leg needs something different. That's going to be the case. The good one, in quotations, I don't like saying good or bad because it makes one feel bad. It's going to hurt the ACL ruptured leg, the feelings of that leg. So I always do that single leg work as well with patients, and keep the good one active as well. You must be proactive. So Ali, you got to be doing some work now, and hopefully you are, but you got to stay on top of things even while you're waiting for surgery. The neuromuscular training perturbation technique, that's shown to be a huge thing as well in research. So So balance training, bow swoop, all that kind of stuff. Perturbations being something external to you. So if you're standing on a ball and standing on a bow swoop ball and you have someone tossing a volleyball or basketball back and forth, that's going to be a perturbation. So that shows benefit. Yeah. So the other thing that I was going to show, which we don't need to see in much detail because it's pretty crazy. I like this because it makes sense to me, but you have all the systems in place of an injury. So you can see that the main thing I want people to see here is very complex. Like, it's not just the knee injured, you have an impact. Like, this even goes into the psychological impact. This is more of like a biopsychosocial point of view. So you can see that there's a psychological impact, intrinsic, extrinsic factors. I just wanted to point here, which is that's where the prehabilitation retraining of brain during resistance training and balance exercise. So it's about getting it early, starting that, and then to improve that loop. So it's just to show that you insert it here and then you improve everything, right? So you have less of a psychological impact, you have more control or more self-efficacy, and then the goal is to kind of reduce that return to play time, or at least to get return to play in a safer manner. So this is a cool thing. It gets pretty complex, so if anybody wants it, just let me know, and I can just switch the slide here. There we go.
I think the neuromuscular aspect of it, like really trying to educate patients on how the brain has a role in their injury, is something that I really, really try and emphasize. And that's kind of where I tie in like a lot of my balance or like more proprioception exercises, but just telling them that, especially people that have been waiting for surgery a long time or their knee's been injured for a really long time, is that there's changes that have been happening to your brain. Like, yes, there's changes in your knee, but there's also these changes that have been happening to the brain. So maybe the balance and the more tedious exercises aren't the ones you enjoy doing the most compared to like a leg press or a squat or something like that, but they're actually the most important, because you can be super strong, but if you have no connection between your brain and your knee, you're at such a high risk for re-injury. So I think, especially for, I know one of my patients is on here, and then Ali as well, like really trying to remind yourself that, especially as you're doing the rehab, if you have exercises that your physio is giving you and you're just like, these are so tedious and so boring, like, remember they're there for a reason, and they're probably the most important ones for sure.
Yeah. The ones that people hate the most are going to be the best for them.
So important. So important. Okay, these are the last couple of slides. I just wanted to throw in a couple of these on the bracing, because again, this is a question that I get a ton from patients, as well as other physios. So this is talking about bracing right after the ACL reconstruction surgery. So what they're finding is that they're doing a ton of studies of this now, and my understanding is that they are moving away from bracing the ACL right after surgery, except for those that have had that meniscal repair. So something that's kind of new in the last couple of years, I believe, because I'm pretty sure before that everybody was braced for X many weeks with just one of those hinge braces. So the results are right there. No clinically important findings of better range of motion with or without the brace. So I think it is up to the surgeon at this point, or until we get better evidence. But then bracing afterwards, like bracing kind of down the line, from what I understand from the surgeons and asking them questions, a lot of it's really up to the patient themselves and kind of their comfort level. Like I said, the brain and the apprehension plays such a big role in getting people back to what they want to do and back to activity. So for somebody that they had this ACL surgery and they would feel better with a brace when they're going skiing or something, I think you can do your rehab. And if you're just going to use that brace as an adjunct to that therapy, then absolutely, I have no problem if they have the funding to encourage them to go that route. But it's just really important to remind people that it doesn't replace your rehab, and it doesn't replace your strength of your knee, and it doesn't replace the proprioception of your knee. It's just an adjunct.
Yeah.
Okay. And then this is just more bracing stuff. The quality of the studies is basically quite poor with all these studies. So really, really considerable sample biases and exclusion biases in all these studies. So hopefully we have better evidence coming up and going forward, but we'll kind of just stay tuned for that.
Awesome. Yeah, and like speaking about the balance and neuromuscular control, everyone should look at the post that I made today.
I was just gonna say that, yeah.
It was perfect timing, and then
it was.
That's
like, actually one of my first things I wanted to talk about from an exercise standpoint was my tips on balance in what I tell patients is that to make it sport specific as early as possible. So if you're treating a basketball player, you're having them stand on one leg and dribble or something, like make it engaging for them. Yeah. Even if it's not like, I mean, if it's a baseball player, you're having them throw a ball with somebody else, right? Like you're just trying to make it as sport specific as you can as early on, because I find that balance is the first thing that people stop doing because they don't think it's important. Yeah. But definitely something that slows you down. And then, or just getting them to stand on one leg when they brush their teeth. That's often something I tell all my patients, like any back or lower extremity injury. That's usually something I tell them on like day 1 or 2, like, yeah, this is really going to help you. You might not believe me now, but trust me, it will. So I usually tell them to do that as well.
That's a good point. Brushing the teeth with one leg. Yeah.
Yeah. I try and do it.
I'll practice that next week when I brush. Oh.
Okay. We'll wait for a story, a live version of it to see. Keep you honest. Yeah. Okay. So one thing I wanted to touch on in the protocol is we talked about this a little bit, is those athletes that are like blowing through the protocol. So they have full extension, they have good SLR, so good quad contraction. The importance of remembering that protocol is in place because that tendon has to turn into a ligament. So that process takes time. So remembering that just because this person has great control, blah, 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 you can't necessarily just rush straight to the plyometrics or return them to sport too early, because that process takes time. Those structures have different properties. So you really have to make sure that you are being conscious of that, and like, yes, make things more engaging. If they are doing well, keep them challenged, but also don't rush things like returning to sport or plyometric training, I think is one of the big takeaways I've had. And then, yeah, I have a few, like the 2 biggest concerns. I have a few like range of motion, like tricks that I've used but most physios probably know them, but we can talk about those. And then I just had like how I progress or start plyometric training. And then also how I progress to that single leg squat stuff, because I find that people, if you just tell them to do a single leg squat, it usually doesn't work very well.
Yeah.
Okay. Where do you want to start? Do you want to do the range of motion, or should we leave that till last?
Your call. I'm good to go. I got a bed right here. I got everything I need.
Okay. Well, let's maybe start with kind of that single leg squat progression. So if you want to go and stand up and just show us kind of your squat technique. Okay. So this is like one of the first things I would do is I would make sure that my patient had like really solid squat control. So good alignment, symmetrical weight distribution. Yeah, so shoulder width apart, whatever you're more comfortable. I know you're a power lifter, so that's probably more comfortable for you.
Yeah, I'll do it how I Olympic lift, I guess.
Okay, sounds good.
I'll pretend I have a bar, but
okay,
running down like that.
Good. And so I'd obviously ask you, if you're my patient, if there was any pain or discomfort with that. It looks really, really good there. So probably to progress you for the first time into like more of a single leg squat, what I usually do is I actually put them more into kind of like a wall squat. So I actually get them against a wall, because this is going to take out the balance aspect of it. I mean, you might have patients that can go, I'll show kind of 2 different ways, but this is like the very beginner. So I get them, to kind of try just a wall squat. So back and hips against the wall, feet, a little bit further out maybe, so that you don't go past your knee, and then just squat down through there and then come back up. Good. And then what I get you to do is I want you to bring, so let's say your left leg is your surgical leg. Bring your, sure, whatever leg. I don't know, is that your right or your left? I think you're mirrored.
This is my left.
Okay, you're mirrored on here. So bring your left leg a little bit more to the midline of your body.
Okay.
And then what you're going to do is you're going to come up onto your right side of your toes. So you're kind of on your tiptoes on that side.
Yeah.
Yep. And then you're going to slide down and do the same thing. So this is just kind of taking the strengthening a little bit more to that left side, which I'm sure you feel now. You're like almost a little bit more to the left. Yeah.
Yeah, that's definitely interesting. Yeah, that's.
So I usually start with that, and then what I do from there is I get them to play around once they're comfortable kind of getting good range of motion. So not necessarily to 90 degrees, but definitely to that like 70-degree mark. Once they feel comfortable and have good quad control at that, then I get them to lift up their foot in the air. So doing that single leg squat kind of against the wall.
Oh.
So keeping the hips nice and level. So making sure that glute med is, engaged, and then come back up. Good. And then I use kind of the same process. So sometimes people find the wall squat a little bit harder, especially if they are not used to doing like a wall squat or things like that. So I use the same process with like just a squat. So I'd start them with a double leg squat, and then I'd progress to either going up on their toes on that side. So you can do the same thing. So going, and then that's going to shift their weight more there. And then even like going more back to like neuro rehab and putting their foot like on something unstable or like a ball or something to really bias that side. And then I would progress them to more of that single leg squatting, things like that.
Yeah. No,
and then obviously using like leg press or something like that is a really nice way to, again, take the balance completely out of it. But I do find that going from a squat and then prescribing a single leg squat often doesn't work. So these are like intermediate steps that I usually use, especially with those people that are having a hard time bending symmetrically through that knee, whether that's because of control, strength, apprehension, whatever that may be.
Yeah. No, it's definitely, those are cool progressions.
Thanks. And then with the plyometrics, I don't know how you usually start, but I usually start with controlling a step down. So do you have a step there, like a smaller one?
Yeah, I do.
So we got a question from Alexandra. How quickly do I tend to progress through these squats? Do you find it about a week between progressions, or does it seem to take patients longer to grasp? So, I mean, definitely dependent on the patient, right? So you have these patients that, depending how active they are too, you have patients that you might need to work like 3 or 4 weeks on just good squat control. You might be able to teach them how to squat correctly in 30-minute session. So it's kind of a loaded question. It's definitely based on patient response. I make sure that they have a good understanding and they have good control in that exercise before, but I can progress it that same day if they get the hang of it, or I get them to work on it for a week or two and then we revisit it and progress it from there.
That's a good answer. Just give me 5. Yeah, sorry. All right.
Patience.
All right. So.
Okay. So I start with, so if your left leg's affected, you're going to start on your right leg.
Yeah.
Good. And you're just going to basically step down and really think about bending your left knee as you land.
Okay. So just kind of.
Yeah. So from there, nice and exaggerated. Then I would get you to add more of like a hop and land. So same things from the right side to the left side, but adding more of that hop.
And you want me to land on both feet, or?
No, just that side.
So just kind of like.
Yeah, exactly. So that's where we would start with like the single leg plyometrics anyways. So what you'll find is that a lot of people will really land with that straight knee. So almost like that peg leg. I'm sure you've seen that. So that's usually where I get them comfortable from there. And then once they have good alignment with there, what you can try and what we test is we actually get you to start on your left leg. So single leg stand on your left leg. Yeah. And then hop down onto that same left leg.
Oh, balance.
So you should be able to hold it for 5 seconds. Good. Sorry? And then you do have quite a bit of a valgum when you land, hey?
Yeah.
So often what I do with this one is I use the slow-mo on the iPhone and I record them and then I show them kind of where their deficits are. So whether that's collapsing through the hip, not bending the knee, the balance aspect. Good. So I take it to there and then I work more on the, once they have a really good handle on that, then I work more on the kind of forward back, side to side, sport specific stuff. But I guess obviously before that, you make sure they're comfortable with like a 2-legged kind of like either like squat to calf raise or things like that. But I do find that often when they're doing double leg plyometrics, like the unaffected is just compensating so much. So I really like this kind of easing them into that plyometric training.
Nice.
Okay.
I like it.
That's kind of all I had. I have some range of motion stuff, but they're mostly just like a lot of L3D for extension, a lot of the patient doing range of motion for flexion. So yeah, lots of movement, lots of biking.
Yeah, that's true. Yeah, the bike's a good friend.
Yeah, always biking.
It's always my first question. Like, do you have a bike? No. Okay, go get a bike.
Yeah, literally always.
No, that's good. I like the plyometric. I like the the wall squat quite a bit. It's
Mm-hmm.
actually a very easy way to progress it. That's definitely something I'll take home for sure.
I think if you can take, I mean, a lot of the times we, especially as physios, we give them so many things to work on. So I find if you can like, basically the wall kind of takes out the balance aspects. You don't have to worry about falling over, right?
Yeah.
So I think if you can take something out and make it them focus on one thing, you're usually more successful.
Yeah, for sure. I agree. Yeah, the plyometrics, good way to, like I've done some of that in the past with some of the athletes, but I know at those times I don't see them as frequently. Like it's more so like the touch base every couple of weeks or 3 weeks. So it's kind of cool to see. That's a cool part for me, is to see the progress when you do them less frequently. And the initial process, yeah, you get quite a bit of that quick progress in the first couple of months, and then I think the psychology behind it is telling people that there's going to be plateaus and stuff like that. And
yeah. And I think to add on to what we told Alexandra, I often give people like progression. So I give them like really clear expectations. So like I'll show them like 3 different stages of the exercise. So keeping it like one exercise. So like say the wall squats, I'll tell them, I want you to do the wall squat. Once you feel comfortable with that and you can get 70 degrees, I want you to move on to lifting your toe up. Once you feel comfortable, and I like, because I don't see them once or twice a week. I see them like every 3 or 4 weeks. So I tell them, and I'm like, and then when we check back in, I'm like, okay, where did you get with this exercise? Like, where are you at now? And then I take what they've done and I progress it from there.
yeah, that's the best way to do it for sure. No, it's interesting to hear all these similar things and like pushing people a little bit more, so to speak, when it's safe. So
Totally. Do we have a couple minutes for questions? I know we only get like an hour on here.
yeah, we can, so guys, just ask whatever questions you like, and we got a few minutes to answer them. And then with the articles or the links, just let me know, and I know there's always a few people that want the articles and links, so just let me know and I can send them to you pretty quickly. You just have to be a little bit patient with me. By the end of the day, I can send them. So I have a wee bit crazy days these days, but
yeah,
hence why. Okay. Yeah, and if you wanted to join in again, for sure, because I think I'm going to change it to 3 times a week, or maybe even just once or twice a week. So I might
Too bad you can't have Laura and me. I feel like that would be a good 5-minute Physio Dynamic for you.
That's true. One of you can move and work here, and then it's
yeah. Yeah, that works too.
But it could just be socially distanced, and that would be good.
Just be in the back.
Yeah, because then, yeah, the idea is to do it once, and then everyone like give me feedback too. Yeah, both of us. Okay, good. We'll make it happen. Or I could just get one on Zoom and then point that to me, and that could work.
I saw a patient for this yesterday. The most important thing prehab for me is that we get that good like biomechanics. So I work a ton on like how you should be squatting, and then finding like, okay, like, are you weak more in like the glutes, or like, is it more like a function of the quads or something like that? So like working with someone that can really like assess your alignment and things like that. And like the alignment is key. And then again, kind of working on that single leg rehab too, like keeping in mind that left and right are going to be different for you. So train it accordingly, right? Otherwise you'll compensate a lot more than you think you are. And then always doing your exercises in front of a mirror is super important, is what I emphasize too.
Yeah.
I don't know if that answered. So a lot of squats, a lot of hip work.
Yeah, I can go like quite a bit of volume. I'm like, well, if it's ruptured, so I just see what people can do, like screen them. The first session's pretty long and seeing what they can do, and then pushing them as much as they can tolerate. So trying to get as much strength and stability to the knee before. And then I know there was some studies, I didn't have them up, but I know when you do prehab, like you shorten, you get full range of motion faster after, less pain, and faster and safer return to activity, return to sport. So that is shown. I just don't have the data.
For sure. Yeah. I really think that moving forward, like the emphasis on prehab should change in our healthcare system, and like really trying to like get people 3 sessions for prehab. Like I'm so curious on how that would change our surgical outcomes, because I mean, these people some people you see and they've been on crutches for 6 months because they've been waiting for their surgery, and you're like, okay, like it's such a different point to start from.
Yeah, I think it could be streamlined. It could be more efficient because then, like, the person's feeling less pain, which is the most important thing, is the patient, and then B, like the stakeholders too, like the healthcare itself would have less expense. I know they do prehab for, and that's kind of limited with knee and hip replacements.
Mm-hmm, mm-hmm.
I think if we did more of with everything, even like knees, shoulders, that kind of stuff, it would be huge because I'm trying to be a big advocate for prehab and trying to tell clients that if you notice something is off, like you can prevent an injury or you can, like the severity won't be as bad.
Minimize, yeah, minimize or mitigate, I guess is a better word, like mitigate the outcome of that for sure. Yeah, agreed.
Yeah, for sure. So
Awesome.
I think that answers that really well, Ellie.
We just went on a rant about something else, but
that's a good thing because like you can't hear people, so we can just literally do whatever we want. So
yeah, just rant about whatever's bugging me.
We'll leave it another minute and then before like it kicks us out. I know sometimes it has a countdown, sometimes it doesn't. I wanted to thank you quite a bit, like so much for today.
No, thank you for having me.
And thanks for what you're doing too with 5-Minute Physio. Like it's really cool, and I think everyone here should follow them for sure and watch everything. Like go back and watch things.
Follow, tag your friends. Yeah. We're gonna release some new content, even though on our ask, a lot of people wanted us to keep it the same. So we appreciate that too. Laura says thanks. But yeah, it's fun. It's been something to keep. We're both quite busy people, so not being super busy has been hard for us. So it's been really fun to work with her, and she puts up with me when I'm very specific about her lighting and her green carpet.
On the carpet. Too bad you can't dye carpet. Yes, the video will be posted on YouTube. I know the ankle one I still have to post it, but it is saved to my computer, so it will be posted, this for sure, and tagged and whatever else I can do on YouTube to promote it more. Yeah, so thanks again.
Yeah, no worries.
Again, if you want to do this more often, that'd be great.
Totally.
Not like putting you on the spot or anything.
Yeah, I'm always down. I love talking.
So 5-Minute Physio guys, you can watch all of their videos in the time it takes to watch one of mine. So, meaning they're more efficient. So if you did a quality improvement study, they're probably far more superior than I am.
No.
And there's 2 of them. So actually there's 3 of them.
There's 3 of us now. Yeah, there is 3 of us now.
Yeah, I keep forgetting. I'll get Rob and Brandon in too. They'll be the whole family.
Perfect. We also have Moose. So Moose is our mascot, Laura's dog.
Yeah.
He's there too.
If he was around, I would do nothing. I would just play with him. So
yeah, he's super cute. He's a very good boy. Okay.
Awesome.
Thank you so much.
Thank you. This was a lot of fun, and thanks to everyone for attending. And yeah.
All right.
You have a great day in Calgary.
You too. Bye-bye.
Bye.